Hello everyone, I'm Yu, a physical therapist. This time, I introduce clinical practice guideline for renal rehabilitation in the academic journal of Renal Replacement Therapy. This divides kidney disease into four groups and describes the intervention for each. Focus on exercise therapy. Now, let's check the contents. First, I talk about Japanese background of chronic kidney disease. The number of patients with CKD has increased to 13.3 million and patients receiving hemodialysis surpassed 320,000. Aging of patients is progressing with mean age at the introduction of dialysis being 69.2 years old and mean age of all dialysis patients being 67.9 years old. Dialysis patients have a poor prognosis at the mortality 3 years after the initiation of dialysis exceeds 30%. Second, I talk about renal rehabilitation. WHO says rehabilitation includes all means to alleviate the effects of conditions that may bring about disabilities and social disadvantages and achieve social integration of people with disabilities and social disadvantages. The Japanese Society of Renal Rehabilitation says renal rehabilitation is a long-term comprehensive program consisting of exercise therapy, diet therapy, and water management, drug therapy, education, physical or mental support, etc. to alleviate physical or mental effects based on kidney disease and dialysis therapy, prolong the life expectancy, and improve psychosocial and occupational circumstances. Talking about the background of preparation of this guideline, the Japanese Society of Renal Rehabilitation was established in 2011, and renal rehabilitation was published in 2012. This guideline aims to optimize the quality, safety, and efficiency and availability of renal rehabilitation service. This guideline is composed of clinical questions of four groups: nephritis, nephrosis, CKD, dialysis therapy, and kidney transplantation. There is summary of the strengths of recommendation and evidence at each clinical question. There are two types of recommendations. One is strongly and two is weakly. And there are four types of evidences. A is strong, B is moderate, C is weak, and D is very weak. Now, let's check the content. Clinical question 1 is that can exercise restriction be recommended for patients with glomerulonephritis? And the recommendation is that exercise restriction is proposed not to be applied to them, although it is necessary to individually evaluate the age and degrees of proteinuria and impairment of renal function. There is no clear evidence that the prognosis of glomerulonephritis is exacerbated by exercise or that the prognosis is improved by rest and exercise restriction. Clinical question 2 is that can rest or exercise restriction be recommended for nephrotic syndrome? And the recommendation is that Excessive rest or exercise restriction is proposed not to be applied to patients showing nephrotic syndrome. There is no clinical evidence that supports exercise restriction in patients with nephrotic syndrome in remission. Talking about renal rehabilitation for patients with non-dialysis dependent CKD, we should consider about these facts. In CKD patients, the physical function is reduced to about 70% compared with healthy individuals. There used to be an opinion-based recommendation for the restriction of physical activity in patients with renal insufficiency. The clinical relevance of exercise therapy in CKD patients has not been established and must be updated through the accumulation of evidences. Clinical question 3 is that is exercise therapy recommended for patients with non-dialysis dependent CKD? And the recommendation is that moderate exercise therapy is recommended for patients with non-dialysis dependent CKD in consideration of their age and physical function. The effect of exercise therapy in patients with non-dialysis dependent CKD was evaluated from the viewpoints of 5 outcomes: death, renal outcome, hospitalization, exercise tolerance, and QOL. In a meta-analysis of 7 studies that compared changes in eGFR, a significant improvement of plus 2.22 was observed by the exercise intervention for 12 to 24 weeks. The beta-O2 peak was examined as an outcome in 9 RCTs. By meta-analysis, heterogeneity was observed, but a significant overall improvement of plus 3.23 was observed as a whole. There have also been 5 RCTs that evaluated the 6 minutes walking distance as an outcome, and as a result of meta-analysis, a significant improvement in the walking distance of plus 51.3 meters was observed in the exercise group. Concerning about the QOL, there have been 3 papers using the SF36 as an evaluation index, 1 using the KDQOL and 2 using original indices for the evaluation. Regarding physical function domains of SF36, meta-analysis indicated significant improvements in QOL in many domains related to fitness. Talking about renal rehabilitation for patients on hemodialysis, with aging of dialysis patients, frail patients are increasing, and improvements in the prognosis, exercise tolerance, QOL, and ADL may be expected by preventing and controlling the progression of frailty by renal rehabilitation. Clinical question 4 is that is exercise therapy useful in dialysis patients? And recommendation is that exercise therapy is recommended for hemodialysis patients because it has been suggested to improve exercise tolerance, walking ability, and physical QOL. The effectiveness of exercise therapy for patients on peritoneal dialysis remains to be discussed in the future due to the limitation of evidence. I will introduce it. The meta-analysis of RCTs concerning the effects of exercise therapy during hemodialysis. A significant improvement in beta-O2 of plus 5.25 was observed in the exercise group. The meta-analysis of RCTs concerning the effects of exercise therapy during hemodialysis. A significant improvement in QOL of physical component summary of plus 7.39 and in QOL of mental component summary of plus 9.46 were observed in the exercise group. The meta-analysis of RCTs concerning the effects of exercise therapy during hemodialysis. A significant improvement in 6 minutes walking distance of plus 30.2 meters was observed in the exercise group. The meta-analysis of RCTs concerning the effects of exercise therapy during hemodialysis. A significant improvement in dialysis efficiency of plus 0.07 was observed in the exercise group. The survival was evaluated by post-hoc analysis, but no significant difference was observed, while the risk difference and point estimate were better in the exercise therapy group. Talking about renal rehabilitation for renal transplant recipients, there are about 1,500 renal transplant recipients with functioning kidney grafts are estimated to be present in Japan, and about 1,600 cases of renal transplantation are carried out annually, and most of them are living donor renal transplants, with the remaining being deceased donor renal transplants from brain dead or non-heart beating individuals. And there is no detailed description about exercise therapy for renal transplant recipients. There are two clinical questions about renal transplant recipients. Clinical question 5 is that does frailty or low physical activity affect the prognosis of them? And recommendation is that there is very weak evidence that frailty or low physical activity affects the prognosis of them. Clinical question 6 is that can exercise therapy be recommended to them? And recommendation is that exercise therapy is proposed to be implemented for them. In my opinion, there are two important recommendations in this guideline. These two have a great impact on my work. First, moderate exercise therapy is recommended for patients with non-dialysis dependent CKD in consideration of their age and physical function. Second, exercise therapy is recommended for hemodialysis patients because it has been suggested to improve exercise tolerance, walking ability, and physical QOL. Thanks for watching. I hope you to comment. See you again in the next video.